To
All right, great. So, good night, everybody. Thanks very much for having me. And very happy to be here and to present today. I'm going to be talking with you about adult sickle cell disease complications. Now, firstly, I do want to make it clear that the presentation is really prepared for patients. So, the language that I'm going to use and how I'm approaching things is really about how patients, different signs and symptoms that patients can look for when it comes to each one of these complications, and some of the steps that they can take, and some of the things that they can talk to with their doctor about. But it's really not purposed for, doctors and healthcare workers to, learn more in-depth scientific details and management details. So that's just something important that I wanted to mention. And for healthcare workers, you can always get these guidelines that we have at the sickle cell unit. And most of what I'm presenting actually is coming from this. So if you're interested, you can get a copy of that book here and you can learn more. So these are some of the things that I'm going to be talking about. Of course, it is adult complications, so things that are predominantly, that predominantly affect children, like diseases of the spleen and so on. I'm not mentioning here. It's going to be very difficult to talk about all the complications that can affect adults in any, great amount of detail. So, um, a lot of what I'm going to be presenting on is definitely focused more on chronic complications. And that's also with the understanding that you would have had recent presentations on some of the more acute things, meaning some of the more sudden complications that can happen. I know you had a recent presentation on pain management and something recent on stroke as well. So we had Dr. Mullings present that recently. So I won't go into too much detail about those things, but I'm going to try my best to stick within time. So this is just talking about the process of what happens with sickle cell disease. So we know that in sickle cell disease, there is hemoglobin that's inside red blood cells, and that hemoglobin is basically abnormal. And of course, under certain, different stressors or environments, like when your oxygen gets low, when you get dehydrated, when there are infections, it can cause these red blood cells to change shape, and not only can they block up blood vessels, but they can also break up. And that process, what happens is that you're going to release different substances, for example, heme that you're seeing here, and that will cause there to be increased stickiness of the blood vessels, but also, as I mentioned, these, now very abnormal red blood cells are going to cause blockages. And the end result of that is that you get a low blood count. And these blocked blood vessels can also cause organ damage. And that's basically the backdrop of what, is happening with all of these complications. So we can try and remember that, and you can see what that whole process looks like. So blocked blood vessels, organ damage, and of course, low blood count. And as I mentioned, damaged blood vessels. Those are the major things that are happening with sickle cell disease. So the first thing that we're going to talk about is definitely diseases of the eye. And basically, if you're looking at this diagram, the retina is basically the light sensitive layer that's at the back of the eye that allows us to see. And in sickle cell disease, sorry about that. Let me see if I can. Oh, you're actually seeing everything. Never mind. Hold on. Okay, sorry about that. I'm on presenter view, so
Yes,
There
we're
is
seeing.
a little
We're
bit of
seeing.
a difference in what I'm seeing, but okay. So
Okay,
in
can
sickle
you hear
cell
me, Dr.
disease,
Ramsay?
what's that?
Okay, I was just saying to you that in the
Right, I thought there was an animation on this slide, but it's fine. You're seeing all the words, right?
yes, we are.
Okay, so I'm gonna
I was
proceed.
gonna
Mhm.
I was gonna say that the last presentation was actually about hydroxyurea, not on stroke. So if you want to say a few words about stroke, please go ahead.
Right,
I mean,
I have some words on it. Of course,
I know it might not be the full thing, you know.
hydroxyurea and stroke, they're gonna come hand in hand.
Yes,
So she
right.
spoke
Yeah,
a lot
right.
about stroke as well, but I do have some slides on it. So
Right.
in sickle cell disease, you do have some of these blockages that I spoke about before, and they can happen in the tiny blood vessels that are in the retina. And I'm going to show you what that looks like. But of course, and we're going to go through the different steps and what can happen at each different stage. But the resulting outcome, of course, is that it can cause vision problems. And as we go through it, the take-home message that I want you to remember is that we want to start looking for these changes at 12 years old by sending you to the eye doctor and repeating that at least every 1 to 2 years, well, basically every year, with the purpose of trying to pick up these changes as early as possible so that it doesn't continue to progress. So the first stage is that we're going to have, as I mentioned, you're going to have some of the tiny blood vessels at the edge of the retina getting blocked. And then at later, stage two, basically, to make up for these blockages, you're going to have new shortcut blood vessels. So you're seeing that shunt that's forming there, that are going to form to try and make up for it. And then eventually, you're going to have a lot more of these forming until it starts to look like a C fan. And the problem with those C-fan looking blood vessels is that they can break away easily and cause lots of vision problems. So one of the first problems that it can cause is that they can break away and they can bleed into the back of the eye. And that can cause sudden blurred vision or dark spots. And additionally, you can have at later stages, scar tissue can form and it can pull the retina away from the back of the eye, which is basically a retinal detachment, and that can lead to permanent vision loss. So see, these are some of the changes that I was talking about. You're seeing that the blood vessels are starting to look like a C-fan, and um, the critical thing, as I mentioned, is that we want to try and pick up these things as early as possible. So we will send you to the eye doctor um, starting at 12 years old and repeating it annually. And the goal is to try and pick it up at those early stages because we don't want it to progress to the stages where you're getting the bleeding and you're getting the retinal detachments and so on. If it does progress, then we can think about doing things like laser treatment, um, different medications like injecting, particular things into the eye. And if you do unfortunately get uh, um, bleeding or a retinal detachment, then we may have to think about surgery. But the critical thing to take away is that we want to start screening you from early to try and prevent it from progressing. There are some other sudden changes that can happen in the eye. So for example, you can get what we call a hyphema. So you can get bleeding in the front part of the eye. That usually can happen after you get some type of minor injury. And it can affect your vision. So you can end up seeing floaters and having sensitivity to light and blurry vision and flashes of light. And of course, this does need urgent evaluation by an eye specialist. And additionally, you can have, just like we mentioned, that you can have blockage of the blood vessels. You can have central retinal artery occlusion, and that can lead to sudden painless loss of vision. So both of these, you would need to get very urgent care in order to prevent that from progressing and becoming permanent in terms of permanent loss of vision. Additionally, persons with sickle cell disease, of course, unfortunately, you can be at an increased risk for getting infections. That's primarily because, the spleen doesn't work as well, and the spleen is often involved in getting rid of certain types of bacteria. And additionally, because of, those different changes in the blood and the blood vessels that we mentioned before. So as a result, it is possible for you to get an infection around the eye, and that can result in basically swelling and redness around the eye. And again, that would need very prompt medical attention. So you'll notice I'm not able to go into total and complete details about these acute complications, these sudden complications that can happen. The takeaway message that I want you to get is that these are not things that you sit around and watch with. They're things that you have to try and get immediate care for. So additionally, the same bone crisis that you're familiar with, that you may get in your limbs, your upper limb and your lower limb and so on. This can also happen around the bone or in the bone that's around the eye, and that can also cause bruising, swelling, and some blurring of your vision. And again, it is important that you get urgent care when it comes to these. Now, before I spoke about basically the blood vessels and how sickle cell disease can not only cause, low blood count and so on, but it can actually damage the blood vessels over time. And another thing that's associated with this is that it can affect your organs in a very unique way. So as we mentioned before, in sickle cell disease, you can have anemia, you can have broken red blood cells, and that can also be associated with blockages in your blood vessels. And over time, as I mentioned, that can damage your blood vessels. Now, the important thing is that as that progresses and you get damage in one organ, it can create a cycle where problems in one organ can cause issues in another. So for example, it can cause problems with the kidney, and that can lead to fluid buildup, that can lead to high blood pressure, and that can put extra strain on the heart and the lungs. You can also, resulting from that, develop heart problems, which can reduce the amount of blood that's effectively getting around the body and reduce the amount of oxygen also that's effectively getting around the body, which can worsen the kidney problems, can make breathing more difficult, and in effect, that would affect the lungs, right? So it would increase the heart's workload and further reduce the amount of oxygen that's getting around. So you can see that it can be a cycle. So let's start by talking about the kidney. So we understand how you can get kidney problems in sickle cell disease. There are many different ways than what I just mentioned. But one of the early signs that we see is that you can start to get protein in the urine. And that can start from early in childhood, and it is common in adults. But what's really important is that we want to be able to pick up when you start to, release the smallest amount of protein that we can, identify that is a problem and that we can do something about it. So what we do is that we try and screen you for that. So we start by doing just some urine tests in the clinic here when you're 4 years old, and then starting at 10 years old and going onwards, we try and do a yearly urine test that we send you to the lab to do. And that will help us to pick up, protein that's passing into the urine that we can try and do something about. So if it is that we find the protein in the urine, then we may want to check to see if it is a urine infection that's causing it, because that is definitely something to think about. So we'll test you for that, and then we'll check back in 3 months If it's still positive at that time, or I should say, if it is very, very high the first time that we check, then we may want to start you on kidney protecting medication and also refer you to the kidney specialist. We'll also advise you to try and avoid medications that can cause harm to the kidneys. So things like, non-steroidal anti-inflammatory drugs like cataflam and so on. Very important for when you have pain, but we'll advise you for when you may want to reduce the amount that you're using. And there is some evidence that is coming out now that hydroxyurea can help to reduce the protein in the urine. And in some situations, we may also advise you to consider that. Now, as I said, the goal is always to pick it up early so that it doesn't progress. But if it does progress to kidney failure, which can happen in about 5 to 18% of patients with sickle cell, well, patients with kidney issues, um, it's something that you will need to be in one of the kidney clinics at one of the larger type A hospitals where they'll discuss many different options with you. So some of them are listed there, including dialysis, erythropoietin, and blood transfusions and a kidney transplant in some cases. But as I've said, the goal is always to pick it up early and try and prevent it from progressing to this stage. Some other kidney problems are that sometimes with sickle cell disease, you can have difficulty concentrating the urine. And as a result, children can have frequent urination or bedwetting, and adults may also wake up at night to urinate. When you notice that, it's also important to make sure that there isn't a urine infection. So we usually check for that. But it's also important that you manage, how you're taking in fluids, trying to avoid it, taking too much fluids close to when you're going to bed. And also retraining yourself in terms of habits, like trying to pass urine right before you go to sleep. So those kind of things can help. And those are some things that we'll advise you on. So I've mentioned urinary tract infections before, and, they are always considered serious when it comes to sickle cell disease. And that's why with each one of those things that I mentioned before, we always try to check to see if that is happening. Of course, how we would really know if it's happening, we can do a screening test here when you come to the clinic, but we'd send you to the lab to do a formal test. And of course, that would need antibiotics for us to treat it. In some cases, for example, if you have repeated infections, we may need to do further tests, like we may need to do an ultrasound of the kidney and the bladder just to see if there are any abnormalities. For example, if you have stones or if you have any other abnormalities in terms of the urinary tract. And definitely when it comes to children, we may need to do a lot more imaging to see what's happening, because they could have, congenital issues, meaning issues that they were born with that we need to screen for. But additionally, we tend to follow them up for a longer period of time just to make sure that they've completely cleared the infections. And still on the kidneys, it is also fairly common for you to pass, well, not for you to be able to see it, but it is possible that you can pass blood in the urine. Again, when that happens, I've mentioned urinary tract infections a few times already. But when that happens, of course, we do want to make sure that you don't have a urinary tract infection or any other abnormality going on, right? So this is when we're seeing it under the microscope or with a urine stick, test stick, but not when you're seeing it with the eye, right? When it is that it's so much that you can see it with the eye, that's a different scenario that would require much more urgent medical care, including not only ruling you out for a urinary tract infection, but doing blood tests to see if you're, clotting your blood properly, doing imaging, so doing the ultrasounds that I mentioned before, and so on. But that would definitely be a more serious scenario that requires more urgent medical care. So we have to keep all of those things in mind. When it comes now to the heart and the lung, there are definitely quite a lot of complications that can happen. I'm going to focus on the major ones. So in terms of both the heart and the lung, it is possible to have what we call pulmonary hypertension. And what that really means is that you have high pressure in the lung arteries. And basically, what can that look like? So you may notice that you have low oxygen. You could notice that you have chronic chest pain, that you're a lot more tired than usual. And, that could be that you have fainting. It could be that you have difficulty breathing at night, or that you need to use a lot of pillows when you're sleeping so that you're able to breathe comfortably. And those are just some things that we may notice. And what your doctor will do is that they'll try and do an ultrasound of the heart. And what that does is that we're trying to see how fast the pressure is, or how high the pressure is, and, in those vessels. And if it passes a certain threshold, then what we'll do is we'll definitely refer you to the lung specialist, again, at one of the type A hospitals that we have. We'll consider hydroxyurea, and we'll also consider other special medications which are available. So that is something definitely to look out for, particularly among pregnant women. It's something we need to think about. All right, so acute chest syndrome, this now is not a chronic issue, not an ongoing issue, but it's one of the sudden complications that can happen. And basically, it's usually caused by an infection, or, the same blocked blood flow that we mentioned before, or sometimes fat from a broken down bone, or a combination of all three. And what it looks like, I'm sure most persons here would have experienced an acute chest syndrome already, but it usually comes with fever, respiratory symptoms, so things like coughing and wheezing, and difficulty breathing. Your oxygen can be low, and it is important that you know what your oxygen is normally like for you when you're not sick and you're sitting in, just a regular room. So your oxygen might be low, and when your doctor, it usually also requires us to do a chest x-ray to confirm it, although, we typically will treat you without necessarily needing to send you out to go and get an x-ray. But on the chest x-ray, we may see new changes or new abnormalities on the chest x-ray. Right, we'll show you new abnormalities on the chest x-ray. Apologies, I think I had flipped the slide. Oh, no, okay. Right, so we would have, right, so we would, in order to actually confirm it, we'd actually need you to go and do a chest x-ray. So this is another case that requires urgent medical care. So, we want to give you antibiotics. Sometimes we may need to do a blood culture test, just to see if anything has gotten into the blood, any, bacteria and so on has gotten into the blood. And we may also need to give you oxygen. We may also need to give you medication to dilate the lung spaces. And very often it requires hospital admission and transfusion. So this is something that you definitely should look out for and seek early treatment if you notice it. This is basically what a chest x-ray looks like. So if you look on the L at the top is showing you the left side, right? So it's switched because of how the photograph is taken. But if you look at the right lower side, you will notice that there are some white hazy streaks. And basically that would show us what is going on in the lung. Now, sickle cell disease can also affect your hips. And, basically what's happening is that the blood supply to the hip bone becomes reduced over time because of some of the changes that we spoke about before. And over time, it can cause the bone to weaken and to gradually collapse. And it can be very common among persons with sickle cell disease. So these are just some of the stages that we see. So you see that it can, before we even see changes on the X-ray, there can be changes happening. Over time, the blood supply becomes compromised and you start to get some of the changes. And then eventually, the head, this is number 3 that I'm showing on that classification. Eventually, the roundness of basically the top of your thigh bone, your femur, you'll notice that the head has kind of lost its round shape. So that's what's happening. So you have a loss of that round shape, and that's definitely going to affect how well it can move within that, that joint space. So that's what we call collapse. And over time, that can lead to arthritis and lots of, damage to the joint. So if we look on this X-ray, that's what we're seeing there on the left. And beside it, you're going to see, so where the arrow is, you can see that there's some changes to the top of the femur there. And beside that is a picture showing hip replacement. And we're going to talk about that in the next slide. So the treatment definitely depends on how severe it is. So, initially, we definitely want to try things like resting it, trying to avoid it, putting weight on the hip as much as possible. And, different medications for pain relief. And also sometimes we can think about doing injections as well that basically can help the joint. So things like bone cement. But over time, if it progresses, which very often does happen, we need to think about surgery. So in the early stages, we can do things to help the bone heal. So things like core compression, which is basically making a tiny hole in the bone to improve blood flow. And at later stages, we can think about bone grafting, which is basically filling small damaged areas with healthy bone. I think in more modern times, we're moving more towards hip replacement, as an, as an option, a more immediate option to these other surgeries that I've mentioned. So what we will do is we'll start off with trying these conservative measures, and we'll refer you to an orthopedic surgeon where they can look on your individual situation and then they can decide, because there are a lot of different factors that go into making these decisions about if you should have surgery and, what type. So I also mentioned that, Dr. Mullings would have spoke about stroke the last time, and she probably spoke about it more in the context of children having a stroke. But what I just wanted to point out here is that a stroke can happen among adults as well. So in this very large study that they had in the United States, you can see that, by age 20, it was about 2% of persons had their first stroke. And this is the type of stroke that's caused by blocked blood vessels. But by age 60, it rose to around 13%. So you can see that it's still definitely happening. And this is even more so when it comes to a stroke that's due to the blood vessels bleeding. So it was about 0.5% by age 20 and went up to 7% by age 60. So it's still something to think about with adults. And these are just some things that they found to be risk factors. So increasing age, high blood pressure, high cholesterol were some important things that we need to consider. And as you can see, these are the images that I have on the right are basically just showing you what a stroke can look like when we do things like MRI scans and CT scans. So in the interest of time, I'm going to pass over the slide, but if you want to come back to it, we can do so at the end. But basically, these are some of the signs that you can see. So you may see weakness. You may have difficulty speaking or swallowing. You could have seizures. You could have a severe headache, and you could have changes in your alertness or your consciousness. And again, this is one of those complications that requires urgent care. So you want to get to, I'm going to say, a hospital as quickly as possible so that you can get a CT scan of the brain. And the mainstay of treatment really is to give you transfusions and in the immediate sense. If you do have seizures, of course, we're going to give you medications to control the seizures as well. And in terms of long-term treatment, we would consider hydroxyurea and sometimes aspirin. So if it is due to blood vessels being blocked, it's something that we might think about. Of course, if you do have any neurological damage, then things like physiotherapy and rehabilitation will also be important. All right, so we're coming towards the end. I know you had a presentation recently on pain management, but I'll talk about it again. So basically, sorry, I'm just checking the slides. Okay. All right, checking the chat, sorry. So additionally, we can, of course, we know about pain crisis attacks, and I'm sure that everybody here would have heard about these or unfortunately experienced these. And they really occur when blood flow in the bones is blocked. And of course, is triggered by cold, stress, and infection. So basically, that process that I spoke about before. Of course, it can be treated with pain medication. So you'd be familiar with opioid medications like morphine and NSAIDs like Cataflam and other medications like Baralgin. But what I do want to say is that it's also important to try and consider other treatments. So there are other things that can help. So things like, cognitive behavioral therapy, massage, etc. And of course, which is the whole take-home message of the presentation is prevention. So what we want to consider is that when these pain attacks become very frequent or when they get to the stage that they are really affecting your daily life, you want to consider using hydroxyurea because that has been proven to be able to, decrease the frequency of these attacks that you're having. Additionally, as patients with sickle cell disease get older, about 20% may develop chronic pain, and a lot of this chronic pain, it can be due to some of the complications that we spoke about before. So of course, if you have hip damage, that can cause chronic pain. But what we're now discovering is that over time, patients with sickle cell disease also develop nerve-related pain. So in a study that we did recently, that was about 20% of adults develop that. So that is something that's important to recognize. The reason why is that if you have that, sometimes those opioid medications can make them worse, right? And so we want to be able to identify when that's happening. How would you know? Sometimes it feels like burning or pricking sensations. And of course, it is pain that tends to come and, it doesn't come in sudden attacks and stop as, let's say, a painful crisis attack does. It's pain that will tend to, stick around. It may have a low level of pain that, is recurrent. So it just comes and goes, that kind of thing. So the pain pattern is one thing, right? It's not sudden pain attacks, but also how it feels. So it's going to be burning, it's going to be pricking. And if you do suspect that that's happening, you can talk to your doctor and they can consider using different medications that, instead of making it worse, will actually help. So things like gabapentin, which I heard, mentioned a couple of times in the discussion before this presentation. All right, so this is my last thing that I'm talking about. So basically, the gallbladder, basically that's a small organ. It is below the liver. And what it does is that it stores and releases something called bile. So bile is basically a digestive fluid, and it has things like water, bile salts, cholesterol, and bilirubin. And it helps to, digest fat that's in the intestine. So in sickle cell disease, because, the red blood cells are breaking down, and that thing I mentioned on the second slide called heme, it's being released and it's being converted into bilirubin. And you're going to get excess bilirubin in the bile. And those basically, that excess bilirubin is basically going to come together and form stones. So that's what we call gallstones. It's very common. It happens in about 70% of patients with sickle cell disease. And it can lead to some complications. So usually you may just have abdominal pain, but sometimes that can become a lot more severe and could suggest that some other things are happening. So if we look on the diagram on the right, you can see the gallbladder. You can see a tube coming from the gallbladder, that's the cystic duct, and a tube coming from above, that's the duct from the liver, and both of them form the common bile duct. So if the stone comes out of the gallbladder and goes into the common bile duct, that can cause, significant problems. And what you may see is things like pale stools, dark urine, and increased jaundice. And that would require urgent medical care because it is a surgical emergency. So you would need to go to hospital very urgently for that. If you can also get infections and inflammation forming, not only in the gallbladder, but it can go up in the whole tract or go down. So you can have it going up towards the liver. You can have it going down towards the pancreas. And those can also be very severe complications. So you can have severe abdominal pain and fever in those cases. As I've mentioned, all of these complications, they're very serious, and you would need to go to hospital immediately, where they will give you antibiotics, pain medication, and also consider removing the gallbladder. So the important part for this discussion is that if you do have issues with the gallbladder, it's always going to be an individualized approach. But something to consider is that it's best to remove the gallbladder when you are well. So when we can actually optimize you for the surgery, and instead of doing open surgery where we open up the whole abdomen, we can do a laparoscopic surgery where basically we just use some holes and we, insert instruments to remove the gallbladder. So it's not opening you all the way up. And you're doing it when you're well and not when you're sick. So that is always preferred. And, that's something that you should discuss with your doctor if the abdominal pain is very frequent, and definitely if it's, affecting your daily quality of life. And this is definitely the second to last slide, but I'm just showing you here. This is a study where they looked at persons who did the gallbladder removal, where it says uncomplicated cholelithiasis. Those are people who were, they were well, so they had the gallstones, but they didn't have any complications at the time. And they compared it to persons who actually had the complications when they did the surgery. And you can see that what it's basically showing us is that in comparison to doing it when you're well, doing the surgery when you have the complications, you have basically about a double the risk of getting a crisis, and your length of stay in hospital is about 2 to 6 times longer. So just showing you that. So just to close, the take-home message really is that prevention is key. And we're encouraging you to come to the unit and have your routine visits. The purpose is to try and screen and try to pick up all of these things from early before they become a problem, right? So we spoke about the kidneys. So the important thing is to do these urine tests from early. We can pick up the protein. When you're passing a very small amount of protein, that's a problem. We can pick it up from early. We can put you on medication to prevent it from getting worse. Same thing with the eyes. We can, have you having those regular eye clinic visits so that we can pick up problems happening with the blood vessels before you have a bleed or you have a retinal detachment. If you're having issues with the heart, with, difficulty breathing, becoming tired very easily, etc., we can consider doing an echocardiogram or other things to see, such as lung function tests and so on, to see what is happening and treating it early. And we spoke about the gallbladder, and if it is that it is an issue, we can try and do elective surgery rather than waiting until you have an emergency and when you're sick. And the same thing for pain and acute chest syndrome. So if you're having lots of pain or lots of acute chest syndrome, which is basically more than 2 per year, and if they're affecting your quality of life, then you want to consider getting hydroxyurea. Starting hydroxyurea can reduce the frequency of both. All right, so thank you.